Good evening everyone present here. Today I am presenting a poster on topic hypokalemic paralysis involving respiratory muscles as a result of distal RTA secondary to primary Sjogren syndrome, which is complicated by pregnancy. Introduction. Hypokalemic paralysis is caused by a number of underlying etiologies, namely genetic, endocrine, gastrointestinal and renal. Renal tubular acidosis and thyrotoxicosis constitute the major cause of acquired hypokalemic paralysis. Distal RTA is one of the common pathway for potassium loss in a variety of diseases, including connective tissue diseases such as Sjogren syndrome, systemic lupus erythematosus, that is SLE, and rheumatoid arthritis. Pregnancy can worsen any type of RTA, adding on to the hypokalemia secondary to RTA. Case history. A 29-year-old female patient P1L1 presented to emergency with complaints of amenorrhea since 8 weeks, weakness of all 4 limbs in 7 days, starting from bilateral lower limb and progressing to involve bilateral upper limbs. Bleeding per vaginum since 4 days, breathing difficulty since 1 day. On examination, blood pressure of patient was 110 by 70 mmHg, heart rate was 104 beats per minute, respiratory rate was 22 cycles per minute, and temperature was 100 degree Fahrenheit. On general examination, pallor was present, icterus clubbing, cyanosis, lymphadenopathy and edema was absent. Power was 1 by 5 in all limbs, all reflexes were preserved, cranial nerves were intact. Per abdomen was soft and tenderness was present in hypogastrium. Based on the history and clinical findings, we make it appeared to be a case of acute flaccid paralysis, which was due to bilateral lower motor neuron pathology. We ruled out anterior horn cell involvement because there was no fasciculation asymmetry or atrophy. We ruled out pathology in neuron, nerve, roots and ganglion, as there was no sensory involvement. Ultimately, we were left with muscle pathology, and possibility of hypokalemic paralysis was kept, and urgent ABG was sent along with routine investigations, including RFT, which were suggestive of normal anion gap metabolic acidosis along with severe hypokalemia. ECG was done that showed QTC prolongation, ST depression, sagging of ST segment, T wave inversion and presence of U waves. On presentation, patient potassium was 1.16, creatinine was 1.09, TLC count was 16.2, HP was 8.8, pH was 7.18 and bicarb was 10.1. Potassium replacement was started and workup of hypokalemia was sent, keeping major possibilities of for etiology of hypokalemic paralysis as renal tubular acidosis versus thyrotoxicosis paralysis, as the anion gap was normal and there was no history of diarrhea. If there was history of diarrhea, we would have also think about VIPoma as the case. Urgent ultrasound of abdomen was done as there was hypogastric tenderness. Ultrasound was suggestive of retained product of conception along with bilateral nephrolithiasis. As all the investigations were being collected, patient developed respiratory distress and sensorium worsened, and patient has to be intubated as severe respiratory acidosis was present, likely due to respiratory muscle involvement secondary to hypokalemia. Dilatation and curettage was done by the on-call obs and gynae team, and potassium replacement was continued. Gradually, patient after potassium supplementation, patient potassium started to improve. Potassium ultimately came on 14th of July. It was 3.16, creatinine was 1.23, TLC count was 34.7, HP was 10.2, pH was 7.31 and bicarb was 14.9. We also sent workup for rheumatological condition, keeping in the mind of Sjogren syndrome and SLE. Anion gap was normal, that is 13. Sodium was 155, chloride was 131, urine pH was 6.8, TSH was 2.2, PTINR was 14.5 and 1.23. Anti-dsDNA was negative and Smith was negative. SSA row 60 was positive and SSA row 52 was positive. SCL 70 was negative. Based on the clinical history of dryness of eyes and mouth prior to the admission along with positive Schirmer's test with all the lab result, diagnosis of distal RTA secondary to Sjogren syndrome was made and sodium bicarbonate was added. Patient started improving and was extubated and later was discharged with precautionary advice during the next pregnancy. Discussion. Our patient has acute flaccid quadriplegia with respiratory involvement secondary to severe hypokalemia due to distal RTA. Diagnosis of distal RTA was suspected on the basis of hyperchloremic metabolic acidosis, normal anion gap and high urinary pH. If the urine pH was low, we could have also think of type 2 RTA, that is type 1 RTA, that is proximal RTA. type 1 RTA, that is proximal RTA. Confirmatory diagnosis of distal RTA was made by positive urine iron gap. Diagnosis of Sjogren syndrome was made by finding of oral and ocular symptoms, positive Schirmer's test, and higher antibodies, anti-SSA, anti-SSB titers. RTA has been subdivided into type 1 and type 2, distal and proximal, and mixed. Secondary to aldosterone deficiency or resistance, that is type 4. Among these, distal RTA is most common. Distal RTA has multiple underlying etiologies, which include primary and idiopathic forms, and more commonly secondary to autoimmune disorders such as Sjogren syndrome or rheumatoid arthritis. Hypo or hypercalcemia or drug toxin exposure. Although distal RTA occurs in 25 to 40% of patients with Sjogren syndrome, it is rarely clinically apparent. Hypokalemia is a presenting manifestation of Sjogren syndrome in around 2% cases. Pregnancy is reported to worsen either type of RTA. In pregnancy, there is mild physiological respiratory alkalosis and hyperfiltration of kidneys, secondary to increased blood volume. This hyperfiltration results in increased loss of some electrolytes, leading to higher requirement of potassium and bicarbonate. Potassium and alkali supplements are indicated in all these cases of distal RTA and Sjogren syndrome. There is no role of immunosuppressive therapy for RTA. Case reports are available for treatment with intravenous cyclophosphamide and steroids, but with no benefits. Conclusion: suspicion of hypokalemic paralysis should always be kept in the case of acute flaccid paralysis, an aspect that is frequently overlooked, especially in peripheral healthcare centers, and should be evaluated and managed earliest to prevent any life-threatening complications like respiratory failure, cardiac arrhythmias, or neurological complication, and improving the outcomes of pregnancy. If patient in current case desires to pursue future pregnancy, early antenatal care and electrolyte monitoring should be considered. High index of suspicion is crucial for early diagnosis and timely treatment, which can significantly influence the clinical course of disease and improvement of patient outcomes. Thank you.